Welcome to our webinar titled, What's My Doctor Thinking? Treating Secondary AML. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for making the program available today. Due to the high volume of programs on the internet, it is possible you may lose your connection during the program. If you're unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Our specialist today is Dr. Firas El Chaer, who is an associate professor of medicine specializing in hematology and oncology. His clinical interests are acute leukemia, chronic leukemia, myelodysplastic syndrome, myeloproliferative disorders, aplastic anemia, colonial hematopoiesis, and blood disorders. His research focuses on improving outcomes for acute leukemia in adults by focusing on targeted therapies and overcoming resistance mechanisms. He attended medical school in Beirut, Lebanon, and completed his internal medicine residency at Mount Sinai in New Jersey, where he served as a chief resident from 2013 to 2014. He then completed a fellowship in infectious diseases for immune-compromised cancer patients at the combined program of Baylor College of Medicine and MD Anderson Cancer Center in Houston, Texas. He pursued a fellowship in hematology and oncology with a focus on blood disorders, and also completed a built-in fellowship in stem cell transplantation at the University of Maryland of Medicine, where he served as a fellow from 2018 to 19. He joined UVA faculty in 2019. With that said, it's my extreme pleasure to welcome Dr. El Chaer.
Thank you, Leigh, so much, and thanks everyone for joining today. Let me share my screen, and we can start. So I was asked to talk today about what we think as physicians when we approach a patient who was diagnosed with secondary AML. The talk is going to be tailored towards patient and families, and if you have any questions, I'm happy to answer at the end. So let's start first with acute myeloid leukemia. I'm going to be referring to it as AML throughout this presentation. So as you all know, our blood is made inside the bone marrow, which is found inside the bones. And this is where the stem cell, which is basically the very original cells in the bone marrow, are housed. Then these stem cells, they give rise to the red blood cells, the platelets, and the white blood cells. The white blood cells help us fight infections. The platelets help us prevent us from bleeding to death. And the red cells is basically what provide oxygen to our organs. As you can see here, these stem cells, if you see on this diagram, they, as they grow, they give rise to 2 primary lineages. You have the myeloid lineage and the lymphoid lineage. Ultimately, the lymphoid lineage will give you the white blood cells that are responsible for our immunity, such as the B cells or the T cells. We're not going to be talking about that today. On the other side, the myeloid stem cells will give rise ultimately to what will become your red blood cells, your platelets, and the other part of the white blood cells, which will ultimately give rise to other immune system cells, such as the neutrophils. We're going to be focusing today on this side of the diagram, which are the myeloid stem cells. In this diagram, you can see just that side that we just talked about. So the stem cells, they give rise to the myeloid stem cells, the myeloid cells, and ultimately they give rise to your monocytes, granulocytes, sites, otherwise known as neutrophils. If anything happens here throughout that process, such as a mutation or an exposure to a carcinogen, which something that give rise to a cancer, any of those cells can become mutated and ultimately can give rise to a cancer of the blood, otherwise known as acute myeloid leukemia or AML. Now, when a patient comes to my office with any symptoms or physical exam concerning for acute myeloid leukemia or AML, the first thing is we have to establish a diagnosis. How to do that? There's multiple ways, either from the peripheral blood or from the bone marrow biopsy. So if you have been diagnosed with AML or a family member, you might have had a bone marrow biopsy aspiration and biopsy. What does that entails? Basically, it's a needle that goes inside the sacrum area, which is the hip area. It goes all the way through the bone, the skin, the bone, and all the way into the spongy part of the bone. This is where the bone marrow or the stem cells are housed. Then, as you can see, the procedure is two parts. There's aspiration and there's biopsy. So basically, as the needle goes in, we aspirate the blood and we send that for multiple tests for analysis, which we will be discussing in a short while. As well, we send a part of that bone for the actual biopsy, which we'll be calling core biopsy. As you can see, this is a better visualization of that particular needle that went inside the spongy bone, and you can see it literally takes part of that bone, which will be analyzed to see if a patient has AML or other blood disorder that we can diagnose using a bone marrow biopsy. Now, when we do that aspiration and biopsy, there are multitude of tests that we can send in order to make a diagnosis. The first one that we just discussed is the core biopsy, which is the actual piece of the bone that we send. As you can see here, in a normal, healthy bone marrow, you can see that there are, which is on the left side here, this is what we see under the microscope when we do the biopsy, the core biopsy. You can see the cells architecture is very well maintained, as well as there's other material inside the bone marrow that give rise, that help these cells to grow and be maintained. You see on the right side, this is a bone marrow biopsy, a core biopsy from a patient who had acute leukemia. You can notice the difference where these cells here are much darker, are much more condensed, and there's much less space for other cells inside the bone marrow. So this is very concerning that the patient might have acute leukemia by just looking at the core biopsy or the actual piece of the bone marrow. The other thing that we analyze is the aspiration that we talked about. So the fluid that we take from the bone marrow, one of the things that we send it for is something called flow cytometry. What is flow cytometry? Flow cytometry, the cells that we took from the bone marrow, we tag them with material that can identify them. Then we tag them further with a fluorescent material that emits light. And they go through an analyzer, as you can see here. As they go through the analyzer, a laser beam is focused on these cells. And as that laser beam is focused on these cells, we can understand and know the cellular complexity, which is how complex each cell from the aspirate is, what is the size of these cells, as well as what particular light is being emitted from these cells. This is extremely important because this will help us identify what is the type of acute leukemia, whether that is AML, acute myeloid leukemia, or some other type of leukemias. The second thing that we send these cells for from the aspiration that we did is something called chromosomal analysis. As you all know, as humans, we have something called a karyotype, which is basically how we analyze the chromosomes inside our cells. We have 22 pairs, basically, which is 44 chromosomes, plus the sex chromosome. If you're a male, you're XY. If you're a female by birth, you're XX. So as you can see, each chromosome, let's say chromosome 1, has 2 copies. These copies, theoretically, they should be identical. If there's any loss of one of these chromosomes at chromosome 1, or any addition of one of those chromosomes, or even if the loss is not complete, even there's only half loss of that chromosome, all of that will cause the cells to mutate and ultimately might lead to cancer, or blood cancer. In this case, it might be acute myeloid leukemia. So this is very important to analyze the karyotype, or basically the chromosomal analysis from these cells, in order to stratify, which we will look at it in a few slides, how we basically stratify these AML. This karyotyping will help us to do that. Next, we sent for something called molecular genetic studies, which is basically, as you all know, there's DNA inside our chromosomes, and that DNA can undergo multiple mutations. And when we look for these mutations, this is called molecular genetic studies. These can be either acquired, most likely, most often, or inherited. We're not going to be focusing about inherited genetic mutations during this webinar. We're going to be focusing about the acquired one, which is basically we are not born with these mutations. We acquire them by the mere fact of living. Each cell is formed of multiple parts. One of them is called the nucleus, which is the center of these cells. That nucleus houses these chromosomes that we just talked about. Each chromosome is made of a sequence of DNA, which basically is very well preserved inside our body. As we get exposed to carcinogen, basically material that can give rise to cancer, as well as if you are predisposed to it, this DNA can develop mutations, and these mutations ultimately could lead to acute leukemia, either one mutation or multiple mutations. I included here this picture that you can see there's a multitude of mutations that can happen. Do not worry about the names. But these mutations, either one or multiple one that can happen, can ultimately lead to acute leukemia, among other cancers. Why this is important? Because as we get to know or identify these mutations, we were able to come up with drugs that can particularly target these mutations and hopefully eliminate these mutations, subsequently putting the leukemia in remission or controlling it. So in 2016, the World Health Organization classified AML into multiple subcategories. There's a new classification that's going to be coming out soon that will be revising this classification, but we will focus on the one that is available now. As you can see, acute myeloid leukemia is divided into multitude of subcategories. You can see that these numbers are basically the chromosomal mutation that happens. And these letters, letters here are basically the mutation that can be found in each, in the cells. So depending on the chromosomal mutations or the mutation that are found inside these cells, the leukemia, in this case, acute myeloid leukemia, is stratified or subclassified. I want you to focus on these two here, which we will be discussing today. AML with myelodysplasia related changes, as well as therapy-related myeloid neoplasm. So secondary AML, which is the topic of our discussion today, is divided into two categories. Number one, it constitutes about 5 to 20% of patients who have AML. So 5 to 20% of them will end up having secondary AML. And obviously, it's increased risk compared to the general population in that particular subcategories. The two subcategories of secondary AML are, the first one is therapy-related AML. What does that mean? It means that if someone has been exposed to a previous chemotherapy or radiation, for example, if someone has breast cancer and they have underwent chemotherapy for that breast cancer, in the coming years after that, they might develop acute myeloid leukemia because of their exposure to chemotherapy. Other patients who might have been exposed to radiation to control some cancer, let's say prostate cancer, they can ultimately develop acute myeloid leukemia. And in that case, because of that exposure to chemotherapy or radiation, it is called therapy-related AML. This does not happen to everyone who is exposed to chemotherapy or radiation, but it is a possibility. That's why every time we treat someone for breast cancer, prostate cancer, or whatever other disease where we give them chemotherapy or radiation, we discuss with the patient, the potential of developing therapy-related AML in the future because of that exposure. The second subcategory for secondary AML is AML evolving from an antecedent hematologic disorder. What does that mean? If some hematological, it means a blood disorder. In this case, it means cancer. So if a patient has history of another blood cancer other than AML in the past, such as myelodysplasia, otherwise known as MDS, myeloproliferative neoplasm, otherwise known as MPN, aplastic anemia, or other hematologic disorders, these cancers or blood cancers, these here, can ultimately develop or transform into AML with or without chemotherapy. So whether that patient who has MDS or MPN has been exposed to chemotherapy or not, can ultimately, their disease can develop into AML. It's just, unfortunately, the nature of the disease. Again, not all of them, a very small subcategory of these patients who have MDS, MPN, or other hematologic disorder, their disease can ultimately progress into AML. So secondary AML is the combination of either therapy-related AML or AML evolving from a precedent or an antecedent hematologic disorder. So a lot of questions that I get when a patient comes to my clinic is, what is my stage of AML when they get diagnosed with secondary AML? In lung cancer, we have stage 1, stage 2, stage 3, stage 4, and in other cancer, we have the same staging. However, in AML in general, and in this topic, we're talking about secondary AML, there is no standard staging system for AML. Once we have AML, that's it. We have AML. There's no stage 1, stage 2, or stage 3. However, the way we talk about AML, we talk about the status of that AML. What does that mean? If the AML is untreated, basically the patient just showed up with that diagnosis, it's called untreated AML. If the AML was treated and is in remission, it's called AML in remission. If the AML was treated, however, the disease did not respond to chemotherapy, it's called refractory AML. If the AML was treated and put into remission, unfortunately, the AML recurs or relapses, then it's called recurrent or relapsed AML. So in a nutshell, these are the stages of AML. They are not the regular staging system that we stratify other tumors, such as stage 1, stage 2, stage 3, or stage 4. In this case, for AML, we have these identification for the disease depending on the treatment and the treatment response. So let's talk about the phases of treatment of secondary AML. So we diagnosed the patient with a bone marrow biopsy. We did the chromosomal analysis. We did flow cytometry. We did a mutation analysis. And then we identified if the patient has secondary AML, whether that is therapy-related or AML coming out from an antecedent hematologic disorder. And we were able to identify the specifics of that AML, and now we call it secondary AML. So how to treat it? There are two phases. Phase 1 is called remission induction therapy, and the second phase is called post-remission therapy. What does that mean? What I tell my patients is if you have a huge bucket and it's full of leukemia, the first step is to put that leukemia in remission, basically to try to cut down on that leukemia cells burden inside that bucket. That is called remission induction. This is the first phase. It basically, we try to kill the leukemia cell in the blood and in the bone marrow. And if we achieve that goal, the leukemia is put into remission. This is true for any other leukemia, whether that is secondary or any other type of AML. If the disease achieves remission after that remission induction therapy, then we move to the second phase, which is called post-remission, after remission therapy. The second phase of treatment, it cannot start unless the first phase was successful. So basically, this is the second phase. It begins after the leukemia is in remission. The goal of this post-remission therapy is to kill any potential remaining leukemia cell that may be active, but may not be active at this current moment. However, if we don't do anything for them, basically, if we don't give that post-remission therapy, they might begin to regrow, and that might ultimately lead to the relapse or the recurrence of the leukemia. So we have two phases, remission induction and post-remission. The first one is very important to put the leukemia in remission, basically to get rid of the bulk of the disease. However, if we stop here, if we stop at the induction therapy, most likely the disease will come back, will relapse. That's why we have to give post-remission therapy, which will hopefully prevent that disease from regrowing and relapsing. So when a patient comes in, again, we diagnose the disease and we trying to treat. What do I take into consideration when formulating a treatment plan? This is very important. So the few things that I looked at. Now, number one is the age of the patient. This is one of the most important characteristics in order to formulate the plan. Leukemia or acute myeloid leukemia, by definition, is a disease of the elderly, or usually the average age of patients who come to my clinic that are above age of 60. So the age of the patient is extremely important in order to formulate a treatment plan. Why? As we get older, we are less likely to be able to withstand higher dose of chemotherapy. So the younger we are, the more likely we're going to be able to tolerate a higher dose of chemotherapy. The older we are, that's not the case. If we give very high dose chemotherapy to someone who's 80 years old, let's say, we will be doing a disservice to them because we will be shortening their lifespan. For those patients who are older, you have to give a more gentler or basically intermediate dose or lower dose chemotherapy in the hope to control their disease without basically causing the death of the patient because of the chemotherapy. There is no consensus. What does mean? Which age group will get the high dose or the lower dose? There's, general concepts. For instance, someone who's 60 years old and who is not in great shape. In great shape, it means that who has maybe other medical problems, or they are not in shape. I cannot give them high dose chemotherapy. Someone who's 65 and who just ran a marathon last week, this is someone who might be eligible for high dose chemotherapy. So everything is in perspective. But in general, the older we are, the less likely we're going to get high dose chemotherapy. Number two, there's something we look at that's called functional or performance status. This is very important too. There's multiple scales that we look at in the clinic to identify what is the performance status of the patient. The most common one that is used is called ECOG, ECOG, which is basically, it's a way to determine how functional the patient is. For example, if the patient spends their time more than 50% in a bed or sedentary lifestyle, and their daily activity are very limited because of whether of their age or other medical problems, their performance status or ECOG status will be decreased, and that would basically preclude them from getting high dose chemotherapy. They would most likely be getting intermediate or lower dose chemotherapy. Number three, what I look at is other medical problems, otherwise known as comorbidities. Someone who's 60 years old, who does not have any other medical problems, and who's active and who has a good performance status, will most likely get high dose chemotherapy. However, someone who has comorbidities or other medical problems, such as, let's say, hypertension, diabetes, heart disease, or who has been a long-standing smoker, who has very much a lot of damage to the lungs, those patients, we cannot give them very high dose chemotherapy. We usually choose lower dose chemotherapy for them. The next, we look at organ status, liver, kidney, lungs, whether that is by laboratory values, we check for these blood tests, or by assessment of these organs. If there's any major damage for these organs, the patient will less likely get high dose chemotherapy. Next, we looked at prior chemotherapy. Remember, we're talking about secondary AML. These patients might have received chemotherapy for other cancers, whether that is breast cancer, prostate cancer, or other cancers. The type of chemotherapy that they have received in the past might prevent us from giving them high-dose chemotherapy. Why? One particular drug class is called anthracycline. There's a maximum dose of it that we can receive throughout our lifetime. A lot of chemotherapy that is given to a multitude of cancer have that molecule inside of them. So the more we are exposed to that molecule, it more builds up in our system as far as, for a lifetime. And then when the leukemia happens, if the patient has achieved their maximum lifetime allowed dose of that particular molecule, I cannot give them a chemotherapy for their leukemia that would include that molecule. Last, we look at the characteristics of the AML. You might remember we talked about molecular genetic testing, which are these very specific mutations that are found inside the leukemia cells. We talked about these mutations giving us the ability to give the patient targeted therapy, which is basically molecules, drugs that would target specifically these mutations. So each leukemia, its characteristics are different, and based on these characteristics, there might be an option for a very specific drugs that would work just for that particular leukemia. So I want to show you this slide, and we will walk through it, about the developments and the treatment of AML, or acute myeloid leukemia, including secondary AML, over the course of the past many years. You can see here that in the 1970s, the first drugs that were approved or showed efficacy in AML, it's a combination of two drugs. The first one is called cytarabine. It's a chemotherapy. It's an intravenous medication. The second one is a family of drugs. It's called anthracycline. So there's multiple subcategories. The combination of these two drugs, the first one is given for 7 days. The second one is given for 3 days. That's what is called 3+7 or 7+3. So 7 days plus 3 days. It became the standard of care for AML and back in the 1970s. And unfortunately, from the 1970 all the way up to in the early 2000s, we had not a single new drug for AML that was approved or showed efficacy. So we were about 45 years just relying on this combination to treat any type of AML. Then in the 2000s, we had really a great development in the treatment of AML. Whether that is with these two drugs, one is called decitabine and another one is called azacitidine, which were approved for patients who have AML. Then in the past 5 years, we had really a major development in the treatment of AML with the approval of many drugs. Some of them are listed here. We will talk about them in a few minutes. As you can see, all of these drugs were approved literally in the past few years. So the first drugs approved for AML were back in the 1970s. there were only two categories of drugs that were combined. One of them is given for 7 days, one of them is given for 3 days. That's why they're called 7+3. Commonly, this term is used to describe the treatment for AML. And then 40 years, nothing happened. And then after that, we had two other drugs that were approved. One is called decitabine, and the other one is called azacitidine. And then in the past 5 years, literally, there's really a lot of advances that happened that approved many other drugs for AML. So in the 1970s, we used to give everyone almost the same drugs. Now, because of these advances, we call it personalized cancer therapy. So as you can see before, everyone gets everything the same. Now, each case of AML is completely different based on these genetic mutations, these chromosomal analysis. We can tailor, personalize the treatment of AML. So we talked about how we come up with a treatment plan for the patients. In the clinic, we divide the patient into two broad categories: medically fit patients and medically frail patients. Again, based on their age, comorbidities, organ status, performance status, and all the things that we discussed. In medically fit patient, which is basically someone who's relatively younger, minimal other medical problems, and who's quite healthy otherwise, besides the AML, we have many options. Options number one is a combination of high-dose chemotherapy. Again, this is a patient who's young and who's medically fit. So usually we try to give them high-dose chemotherapy. We can add targeted therapy, which is basically the drugs that specifically work on specific mutations, if these mutations are found in that AML. We talked about, I showed you this before. These are the very different mutations that can be found. Not all of them, some of them, they have targeted therapy, oral drug in most cases, that can act on each and every specific mutation. The most common combination of high-dose chemotherapy, we just mentioned it in the previous slide, is cytarabine plus anthracycline. Again, this is given for 7 days. This is given for 3 days. That's why it's called 7+3. This has been used for, at least 50, 60 years now, and we're very comfortable using this medication. We know the side effect profile. We know how to manage that, and usually we know the expectation of the response of AML if that combination is used. There's another drug that was approved by the FDA a few years ago. It's called CPX-351. It's a very specific drug, and that is approved for secondary AML, or AML that is has an antecedent hematologic disorder, primarily MDS. Why this drug? Because it's a combination of two molecules. It's a combination of this and that in a very specific molecular ratio. So there's a very specific ratio that combine these two drugs. Not only that, it is attached to something called liposomal molecule. What does that mean? It means that the attachment of that molecule to a very fixed molecular ratio of these two drugs is thought to be to allow this drug to enter the cell, the stem cells inside the bone marrow more readily, and will kill the leukemia cells in a much better way. A lot of centers across the country and across the world use that combination, or that drug, use this particular drug for this particular disease, secondary AML, because of a clinical trial that showed potentially there's a benefit of this particular drug for this particular AML. It's an intravenous drug that is given inside the hospital, usually in an inpatient inside the hospital. It has good activity in that particular disease. As you can see here, there's other regimen, there's other high-dose chemotherapy options for this particular disease. I'm not going to discuss them now because, these other chemotherapy regimen are very institutionally specific to each institution. And honestly, most of them, they have very similar efficacy and side effect profile. So these high-dose chemotherapy regimen, most of them have almost the same side effect profile as this one. The response rate is very similar to this one. So whether a physician chooses this combination or another high-dose chemotherapy regimen, would be potentially a good option for the patient. The last thing I want to discuss in this particular slide is clinical trials, extremely important. All of these targeted therapies for these particular mutations, they would not have been approved if we have not been able to test them, starting from the lab, animals, and then ultimately humans, in order to see how efficacious they are or how much they can control the leukemia. So clinical trials are extremely important in AML or any other type of cancer, because this is what allow us to advance the field and hoping ultimately to cure this disease. So clinical trials is whether that is a novel agent, a new agent, or a new combination of a previously used medications. So if a clinical trial is available at any institution, and if you are a AML patient or secondary AML, a patient with AML or secondary AML, a clinical trial is always a good option if it shows some efficacy in that particular disease. Because of secondary AML, it's a high-risk disease. So basically, after the patient gets any type of chemotherapy and they are medically fit, usually that is followed by allogeneic stem cell transplantation, otherwise known as bone marrow transplantations. Allogeneic means receiving a stem cell from someone else, from a donor, whether that donor is a sibling, whether that donor is someone random person in the world who matches us, or if that person, that donor is a child or a parent. I'm not going to go into the details, but allogeneic means someone else is giving us their cells. And obviously, we're doing stem cell transplantation. And some books or some advertisement, you might hear the word bone marrow transplantation. It's two words, either stem cell or bone marrow, for the same procedure. So medically fit patients, they undergo remission induction. We talked about it before. And after that, they undergo post-remission therapy, otherwise known as consolidation. And then most of them, if they are medically fit, they will end up with an allogeneic stem cell transplantation. I'm going to show you a patient case. So a 50-year-old female with a history of breast cancer, she completed chemotherapy and radiation therapy for the breast cancer, cured. Unfortunately, 10 years later, she presented with a decreased white blood cell count and anemia, decreased red cell count. A bone marrow biopsy was performed, and it showed that this patient developed therapy-related AML. So it is AML. Why is it called therapy? Because she received radiation and chemotherapy for her breast cancer. She underwent induction chemotherapy, otherwise known as remission chemotherapy, with high-dose chemotherapy. We talked, she's medically fit. We repeated the bone marrow biopsy. It showed that her leukemia is in remission. We proceeded to consolidation chemotherapy or post-remission chemotherapy to get rid of any leftover leukemia and make sure the leukemia doesn't come back. And then, just because it is therapy-related AML and the patient is fit, most likely all of these patients will undergo allogeneic stem cell transplantation. This is a very common scenario of therapy-related AML, as far as treatment modality and how things progress in the clinic and the hospital for these patients. Why, again, she underwent high-dose chemotherapy? Because she had excellent performance status, she had preserved organ function, and she had minimal comorbidities or other medical problems. Now, medically frail patients that we talked about, whether that is due to age, very old patients or elderly patients, whether the patient has many other medical problems, prevent them from getting high-dose chemotherapy. Usually we offer them a lower dose or lower intensity chemotherapy in the hope of controlling their disease and extending their survival, prolonging their life, and hopefully offering them a good quality of life. So what are our options? And those patients, I cannot give them, or we cannot give them high-dose chemotherapy. We resort to other less intense chemotherapy options. Number one, there's a family of drugs called hypomethylating agents. The two now that are approved for this disease, for AML, or that we use for AML. The first one is called azacitidine. The second one is called decitabine. About 2 years ago or so, we were just using one of those medications for the patients who are medically frail and who have AML. 2 years ago, or now almost 2 years ago, a new medication called venetoclax. It's an oral pill. These two are either IV or subcutaneous under the skin, or intravenous IV. This one, venetoclax, is an oral medication that is combined with one of those medication that showed that the patients who received this combination, one of those plus this one, venetoclax, had a better remission rate, better control rate of their leukemia, and lived longer when we compared those patients who received this combination to those who received one of these drugs without venetoclax. I will show you in a second the clinical trial for that. Number two, another combination that we use is a lower dose of that cytarabine drug that we talked about before. We don't give here the high dose of form of it. We give the low dose, which is usually a subcutaneous formulation, in addition to this oral pill venetoclax. Number three, if the patient disease has a mutation that is targetable, for which we have an oral or an intravenous or any other form of a very specific drug that can kill or control that particular mutation, we can use that. This is called targeted therapy. As you can see here, again, this is the slide or the picture about these mutations. For instance, if the patient's disease has this mutation, FLT3, FLT3-ITD, the patient might be eligible to receive a medication called gilteritinib, which is approved for that particular mutation. If the patient, let's say, has IDH1 mutation, their disease, they can be eligible for a oral molecule called ifosfamide. If the patient's disease has IDH2 mutation, they can be eligible to receive a medication called enacetinib, which is another oral medication that can target this particular mutation. Whether that targeted therapy is given alone or in addition to another chemotherapy, this is to the discretion of the treating physician, and depending on whether a clinical trial is available at that institution or not. Number four is other low-dose chemotherapy. So there's other options that can provide some benefit for the disease. They're not usually as good as what we just discussed, but in some instances, we resort to these options if a clinical trial is not available, or if the patient is not eligible for the clinical trial, and we still try to control the disease and provide them with a decent quality of life. Always, a clinical trial is a great option for patients with AML, particularly secondary AML, particularly if the disease has not responded to one of these options. We talked about the combination. I'm going to go back to the slide here. Azacitidine plus venetoclax, or decitabine plus venetoclax. This is the clinical trial publication that came out in 2020 that showed that the combination is better than the single agent. When the single agent was combined with placebo, the combination of venetoclax with azacitidine provided a better remission rate for the patients with AML, as well as it allowed them or gave them the opportunity to live longer. And in this trial, when they enrolled the patients, about 25% of them had secondary AML. So we can treat the patients who are medically frail or unfit for high-dose chemotherapy with this combination, which showed a better remission rate and a prolonged overall survival compared to the single-agent chemotherapy. And in this trial, patients with secondary AML were included. I'm going to give you an example of how this two combination is given. So whether you use decitabine or azacitidine, if you use decitabine, this medication is given for 5 or 10 consecutive days. I showed here the 5 consecutive days. If your doctor chooses azacitidine, this is given on 7 consecutive days. And usually these drugs are combined with the oral pill, venetoclax. The oral pill is given on a ramp-up schedule, which is basically we start slowly increasing the dose of that oral pill in order to prevent side effects from this medication. That pill, the venetoclax, is given usually for 28 consecutive days. So they're combined. Whether this one is used for 5 days or this one is used for 7 days, either one is combined with the venetoclax for 28 days. This whole thing here, the 28 days, is called a cycle, or the first cycle in this case. Usually, the patient somewhere here, after day 21, they get a repeat bone marrow biopsy to assess their disease response. If their disease responded, they continue on this combination, usually indefinitely. So what I tell my patients, if we start this combination for them, and if we are able to put their disease in remission, I tell them to consider their AML as high blood pressure or diabetes or any other chronic disease that we have to keep on taking the medication for it in order to keep it under control. So in that case, I see so many patients in my clinic with AML who are cannot get high-dose chemotherapy, who are on this combination of chemotherapy with a disease in remission. Once it is in remission, most of them, they enjoy a good quality of life, and they come to my clinic, and they after they get the chemotherapy, they spend time with the family. They some of them have traveled to their vacations while taking this medication. So this is the goal here, is to control their disease and provide them a good quality of life. A patient case about someone who's medically frail, medically unfit for high-dose chemotherapy. So an 80 years old male here with a history of diabetes and heart disease, who presented with anemia and low platelet count. He underwent bone marrow biopsy and aspiration. It showed AML with MDS-related changes, basically with an antecedent hematologic disorder. Because of the age and other comorbidities, we elected to start him on a combination of azacitidine and venetoclax. We repeated the bone marrow biopsy after 1 cycle, and it showed that his disease was in remission. Because of that, they continued on chemotherapy. After 1.5 years in this gentleman's case, unfortunately, his disease recurred. There was evidence of recurrence of his disease. At this time, his disease showed that it has a mutation. In this case, it was an IDH2 mutation that provided him with the opportunity to go on targeted therapy with an IDH2 inhibitor, basically a molecule that inhibit or try to get rid of that mutation, which is here in this case could be contributing to the formation of the AML. After we started that particular patient on the targeted therapy, we repeated the bone marrow biopsy, and in that case, it showed remission. So as you can see in this case, it's an evolution, it's evolving treatment options. Once you use something in the future, if the disease or when the disease comes back, you can use something else depending on the new finding in the new bone marrow biopsy that would open up other options for the patient treatment plan. Why we chose this combination for this patient? Again, it's an older patient, 80 years old. The patient had comorbidities, heart disease, diabetes in this case. So I'm going to go back to the slide that we talked about the development of these drugs for the AML. In this case, secondary AML is included in the general treatment of AML. In the 1970s, we had only these 2 options. Nowadays, in 2020, we have a multitude of options in addition to clinical trial. And as you can see from the previous slide, the patient case that we discussed, because of that evolution of the disease, as well as the targeted therapy, the new mutation that we found, we were able to provide a personalized cancer therapy for this patient, which basically works on his particular leukemia because of that mutation. I think that's it for today that what I prepared. I'm happy to answer any question that you might have. Thank you so much for this opportunity.
Thank you so much for the wonderful presentation. And we have a few questions. Our first question, they'd like to know, how long did the 80-year-old male patient survive? If you can answer that.
I'm going to answer in a general term. And the clinical trial that combined azacitidine with venetoclax, the median, or basically the average time the patients remained on this combination of therapy is about 1.5 to 2 years before their disease progressed and they were switched to a different type of therapy. This is in general term. When we do the bone marrow biopsy for these patients, after we give them the induction, right, in the remission phase, there are many things that we looked at. There's something very important that we look at. It's called MRD, or measurable. In the old days, it used to be known as minimal. So measurable residual disease, which is the very, very small levels of the disease in the bone marrow of those patients. It's a very specialized test. If that is negative, those subcategory of patients, usually they live longer and they stay longer on this combination of therapy. So again, that particular combination, it serves the patients on an average of 1.5, to 2 years before their disease progresses. However, again, this is the median. This is not true for each patient. In my clinic, some patients that I've seen, they've been on this combination for much longer than that. And unfortunately, other patients, they could not make it to that much time on the therapy. Again, it all depends on the mutations of the AML that are found in the AML. Some mutations are much higher risk and that unfortunately, make the disease come back much earlier. And other mutations allow this combination of drug to work much better.
Thank you. Our next question is, does a TP53 mutation change the treatment?
Great question. So TP53 is a very challenging mutation. In this case, to date, in 2022, we don't have a targeted therapy for TP53 yet approved by at least the FDA. And there's many clinical trials that are evaluating a multitude of molecules in order to target TP53. Now, for someone who's, let's say, older patient, we still use the same combination that we just talked about, a hypomethylating agent, whether that is azacitidine or decitabine, plus venetoclax. So there is no targeted therapy yet for TP53.
Thank you. Our next question is, what is your understanding of the ASXL1 mutation? What is the likelihood that mutation will cause a patient to relapse? And will the relapse begin MDS again or AML? What treatment can be put in place to prevent relapse?
ASXL1 is, again, one of the higher risk mutations that would, make the disease higher risk. The combination of the drugs, again, that we use for this, for the disease, in many instances, it controls the disease even with the presence of ASXL1 mutation. Now, when the disease comes back, it can come back as MDS or AML. There's really no preference because of the mutation itself, whether it will come back MDS or AML. And even if it comes back as MDS or AML, at that point, if a clinical trial is available, that is the best option to offer for the patient to improve their disease and prolong survival.
Thank you. Our next question is, how advanced can someone's AML be for them to still qualify for a bone marrow transplant?
That's a good question. I'm going to talk about our institution at UVA. Usually, and this is, again, not true for everyone because we take a lot of factors into consideration. Age, comorbidities, we talked about them, performance status, organ status, yada, yada. Usually someone who's above the age of 75, they are less likely to get an allogeneic stem cell transplantation for the reason that in those cases, the benefits of allogeneic stem cell or the risks of allogeneic stem cell transplantation outweigh the benefit in those particular patient population. However, if someone comes to my clinic and who's, let's say, 65 years old, some of those patients, they still cannot get allogeneic despite being younger than 75 if they have major other medical problems. So the cutoff is not really set in stone. We look at a lot of things when we make those decisions. We don't make those decisions. I don't make them by myself. It's a team, right? It's me, my other colleagues who do stem cell transplantation. It's a whole team. So in general, 75 is the cutoff. But again, if someone who's younger and who has many other medical problems, they might not be eligible for that procedure.
Thank you. Our next question is, can a person sustain a bone marrow transplant with thrombocytopenia? This person has the inability to produce platelets and retain them even after having a transfusion.
Yeah, absolutely. There's either something called complete remission, which is basically if the patient's disease burden or the leukemia has been cut down significantly. Usually the magic number that we look at is less than 5%. And in some patients, they might have recovered their white blood cell count, their red blood cell count, and their platelet count. In other patients, one of those, the white, the red, or the platelet, might have not recovered completely. In this case, it's called a complete remission with incomplete count recovery. Those patients are still offered allogeneic stem cell transplantation, yes.
Thank you. Our next question is, does taking of luspatercept ever provoke AML in MDS patients? What is your instinct about luspatercept? Can a patient be on it indefinitely? What are the negative side effects? And what number hemoglobin do you stop it or perhaps lower the dose? Do you know of any patients who have ever had a stroke taking this drug?
All right, so just to put everyone up to speed, luspatercept is a subcutaneous injection that is given for MDS or myelodysplastic patients who primarily suffer from a low anemia or low hemoglobin or anemia. It is currently approved by the FDA for a very specific subset of MDS patients. We cannot give it to everyone because of the way it was studied in the patient population. This current medication, in my experience, it's very well it's very well tolerated, and it works in the low risk MDS patients. So when a patient comes to my clinic and they have MDS, we stratify their disease based on a calculation, and that calculation, if the patient has low risk disease and they have anemia or low red cells, and they have particular mutations in their bone marrow that would make them eligible to get this medication, yes, luspatercept is a great option for them. It helps the patients and it makes their anemia get better. I have patients who've been on this medication for a year, 2, 3 years, receiving this medication, and their hemoglobin or their anemia has improved significantly. There's very specific guidelines, or the FDA has given very specific instructions how to dose this medication. It all depends how their disease is responding, as well as what is the level of their anemia. In some patients, for instance, whose hemoglobin is above 11.5 and whose dose is working, in some instances, I hold the dose. I stop it until their hemoglobin goes down, and then we can restart this medication. There's 3 dosing levels of this medication, and patients who have not responded to the first dose, we can go up to the second dose, we can go up to the third dose if they have not responded, but beyond that, if their disease have not responded, the medication could stop. I have given it to many patients. We have a clinical trial here at UVA comparing luspatercept to other injections and the frontline treatment of MDS. So if the patient has very specific mutation inside their disease, the MDS, and it's still low risk, yes, luspatercept is a good option.
Thank you. And our last question will be, how does a patient who wants a good quality of life decide on therapy? If it's grueling, such as 7+3, is it worth it if a patient's only going to gain a few months of life?
This is a great question. And this is literally my personal daily struggle when I offer this chemotherapy to the patient. It's a personalized decision. So my philosophy in my clinic is I discuss with the patient and their family and their support system about the details of the chemotherapy, about the objectives and the goals. 7+3, whoever wrote that decision, that question, is a combination of two drugs, cytarabine and anthracycline. It's a very high dose chemotherapy that's given for medically fit patients. It definitely has a lot of side effects. Particularly, it can cause very severe infections, prolonged hospitalization, among many other side effects. However, if we don't do anything for the leukemia, uniformly, AML is lethal. So I always look at the alternative that if we don't do anything, it is uniformly lethal. The combination of this drug for someone who's young and minimal comorbidities, it has a very good chance of controlling their disease, putting it into remission. And if their disease is secondary AML that we just discussed, an allogeneic followed by an allogeneic stem cell transplantation is the standard of care. I understand that there's reluctance, to get these drugs for AML if someone is looking only at short-term quality of life, but it would be really important to think about long-term survival once we get over the hump of that initial induction phase, which can be very difficult.
Thank you so much.
Oh, absolutely.
For the wonderful presentation today and sharing your time and your expertise with all of us and answering all of those wonderful questions. For anyone listening, if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please feel free to send it to us at any time in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820. Submit a question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program. Thank you again.